29-year-old Caucasian male who presented to the ER for constipation and altered mental status. He was brought in by his daughter, who noticed a change from his baseline cognition. His baseline cognition was alert and oriented times 4. On presentation, he was only alert and oriented times 1. His past medical history is significant for hypertension, AFib, diabetes type 2, hyperlipidemia, history of prostate cancer treated by radiation, BPH, and dementia. The constipation has been going on for about 2 weeks, stated by his daughter. He's had no bowel movements, and she's not noticed any straining while trying to defecate. There's been no changes in diet or activity. The daughter did not notice any abdominal pain, nausea, vomiting, flatulence, melena, and hematochezia. The patient was able to report these symptoms or deny these symptoms to the daughter in the past 2 weeks. Pertinent positives include somnolence, lethargy, decreased appetite, and increased agitation. Pertinent negatives include fever, chills, shortness of breath, and chest pain. For the objective portion of the SOAP, his blood pressure, the vitals were the blood pressure of 117/54, temperature 37, pulse 95, O2 saturation 93% on room air. He weighs 83 kilograms and is 185 centimeters tall with a BMI of 24. On physical exam, he was alert and oriented times 1 to name only. He had an irregular rhythm with a regular rate. His lungs were clear to auscultation bilaterally, no wheezes, rhonchi, or rales. The abdomen was distended but soft. There's no tenderness to palpation, no rebound tenderness or guarding. The rectal exam showed impaction of stool present in the rectum. We worked him up for constipation and altered mental status. His chronic AFib, diabetes, and BPH were all controlled on admission. For the constipation, we did a KUB, which showed a 7.5 centimeter mass located in the intestines and down into the rectum. We treated him with a suppository Q daily until he had the bowel movement. For the altered mental status, we prescribed risperidol 0.5 milligrams Q daily PRN and monitored his urine input and output, looking for urinary retention, and we were suspicious of a UTI. I chose the topic of constipation because I spent the last month on the H unit, the acute care for the elderly at John Seeley Hospital. Most of my patients had acute or chronic constipation, and this interfered with their quality of life. It was frustrating to both the patients and the nurses and the medical team when a patient was constipated, so I researched more about the treatment. My PICO for the population is males and female patients above 65 with constipation. The intervention in and for my study, it showed the intervention and the research of my study was over bulking agents, stool softeners, and osmotic agents. The comparison was no pharmacologic treatment, and the outcome of this article showed that more treatment was necessary to determine the best outcome of the treatment of constipation, and that treatment should look at the entire patient instead of focusing on just the constipation. My article was a meta-analysis titled A Review of Laxative Therapies for Treatment of Chronic Constipation in Older Adults. It was published in 2015. This study compared all types of constipation treatment options and concluded that there's a difference between elderly adults and older adults, and that elderly adults need to be treated more based on their overall healthcare picture, which includes nutrition status, mental cognition, ambulatory status, and their quality of life. So these things along with other comorbidities need to be addressed when treating their constipation.